In 2013, approximately 1 in every 9 maternal deaths that occurred globally took place in Nigeria. According to the National Primary Healthcare Development Agency, a large number of Nigerian women from low-income households did not use health facilities, and the chances of giving birth with skilled help were as low as 1 in 7. With over 500 deaths per 100,000 live births, the nation was recording one of the worst maternal and child health statistics in the world. Despite significant investments in the health sector, very little progress was being made in changing these poor health statistics until 2012, when the federal government, assisted by the World Bank, introduced a revolutionary approach to primary health care through the Nigeria State Health Investment Project, NSHIP.
The bank did what we call peace building and rapid assessment in the entire region. They are really in bad shapes. Bad shapes in terms of what we are looking for. The hygiene, the waste disposal, the human resources, both in terms of number and in terms of the distribution. People you want to see on ground, in health centers, and things like that.
The efforts we're making in the country is more at the secondary and tertiary level. The primary health care is not getting enough or adequate attention the way it should get. So that makes it a challenge for the health sector as a whole.
Designed by the country's leading healthcare institutions and supported by the World Bank, NSHIP was a $170 million life injection into Nigeria's health sector with the aim of reversing the tide and improving health indices in the country by ensuring equal access to key health interventions, especially in rural areas where most of the poor live.
NSHIP as a whole is a Nigerian State Health Investment Project, and is a new approach. New approach in the sense that it pays for outputs and not inputs. By focusing on outputs, what we are saying in essence is that, what gets to the people is the service that they receive at the end of the day. Whether we bought vaccine or we bought syringes and we bought all these things, if children are not immunized, then we have not achieved what we are saying. So we say, okay, if you immunize these children, with government of Nigeria providing the inputs for you, if you immunize these children, we will buy that service. And that's exactly what we have been doing.
Unlike previous interventions that had not recorded much progress, NSHIP was designed to succeed from inception. Why? Because of PBF. PBF, or performance-based financing, is what makes NSHIP unique. In performance-based financing, health facilities are paid directly based on the quantity and quality of services that they render. The aim was to reward health facilities and health workers strictly on their performance.
Previously, we would measure performance and well-being in the sector using input. How much money are we putting? How many doctors are we employed? How many nurses are there? But to me, they do not really tell a good story as to how well that really sector has performed.
This project looks critically at the outcomes of the interventions, not necessarily so much on the inputs. So what the NSHIP project does is make that clear distinction and ensure that we're able to say this is where our money is going and what the money is doing based on the ability of the health managers to really achieve clear indicators. Before the project started, the health workers, they have to, irrespective of whatever they do, at the end of the month, their salary comes. But since NSHIP had started, that's put in place a system in which the quantity of service of work a health worker has put is being assessed. We are now seeing a difference from what it used to be before. The onus is now on the various facility managers and their staff to make sure that they develop strategies, we call them advanced strategies, to get communities to come and patronize it.
NSHIP was piloted in 3 states, Ondo, Nasarawa and Adamawa, and select health facilities each received a seed grant. For the first time in recent memory, each health facility had autonomy to decide how exactly they wanted to spend their funds. And based on their most pressing needs, everyone went to work, with the majority focusing on giving their facilities a much-needed facelift. Today, the project is implemented in all 52 local government areas of the 3 states, covering 1,470 primary and secondary health facilities. And after just a few months, the results started to come in.
We have seen unbelievable improvement in the attitudes of workers, health workers, the same people that once upon a time you hardly will see them at the clinic, especially on weekends. And these are the same people now, day and night, day. Some even want to sleep in the facility.
Tó bá dé dé ní 24 hours a day, bàbá nurse, bàbá òṣìṣẹ́, àwọn tí dárí tabari patient tó jẹ́ pé ara ọwọ́ nurse ò ká, wọ́n á pe doctor adéwà, attend sí. Tó bá jẹ́ lé tó máa admit, tó bá dé jẹ́ lé tó máa treat yẹ. In the
PBF approach, payment is explicitly tied to the delivery of pre-agreed health services. And because the health officers know that their funding is closely tied to the quantity and quality of the healthcare they deliver, they use the funds they receive to create a more conducive environment for the women and children and reward the hospital staff, who in turn are now motivated to dispense better healthcare. So, for the healthcare workers, the more patients they can accommodate and care for, the more they can earn.
It's a performance-based financing program, and so you earn based on your performance. And so because of the earnings the facilities are receiving, you are able to procure drugs, you are able to at least recruit additional manpower. And even the LGA was able to carry out its traditional responsibility as going out for integrated supportive supervision, carrying out quality assessments, assessment of the facilities that are conducting this program.
There has been significant improvement in service use, particularly for skilled delivery, family planning and immunization.
Since NSHIP is looking at financing the outputs of the services also became more focused on the results, and that's automatically improved the participation at the community level, where there is joint planning. With the re-establishment of the World Development Committees, the health units became more engaging with the communities, and that's helped to overturn things within the shortest possible time.
Since payment is based strictly on the quantity and quality of healthcare that the health facilities claim they deliver, one vital contributor to the PBF records of success is the verification process. The trained team of verifiers ensure that claims are verified before payments can be made, and they also provide mentoring and coaching for the hospital staff, guiding them on how to properly prepare their business plans and invest their funds to deliver even better results.
Verification under the PBF model is very important because the PBF reward performance. We talk about reward of performance in the sense that they purchase the services. Any service that has been claimed will be remunerated. So any place that money is involved, if verification does not go hand in hand with that, people can easily falsify data.
This is a paradigm shift from the way we do things before, and it gives a lot of power to the people at the health facility level, a lot of resources for them, focus or target kind of resources that they really require to make a lot of difference at that level.
Today, thanks to NSHIP, more children are being vaccinated, more women are making use of skilled birth attendants, and more lives are being saved. Statistics now show that the number of infants that are fully immunized have increased 4-fold since the beginning of the project. Also, births attended by skilled helps have gone up over 600% in the 3 states, Quality of care has also improved, with the average health facility quality of care score increasing by over 40%. As a result of the successes recorded so far in the pilot states, NSHIP has now been scaled up to include 5 more states: Bauchi, Gombe, Taraba, Borno, and Yobe, due to the exceptionally poor health indices in the northeast made worse by insurgency. The hope is that the successes recorded in Ondo, Nasarawa, and Adamawa will be replicated in the 5 new states.
NSHIP has stimulated a lot of things, has developed capacities of the communities, has also changed the landscape of the infrastructure of the health facilities and the acceptance and the participation by the communities.
These are beautiful things about NSHIP, and to me, we need to sustain this in order to keep it going.
The National Health Facility Survey that was conducted very recently in 36 states. Adamawa State came first in the country, Ondo State second, and Nasarawa State third. This cannot just be by chance. It has to be that by something has happened, to take them from where they were before, to being the #1 in the country.
Health is wealth, and if Nigeria must continue on her march to improving the lives of her citizens, special focus must be placed on saving lives, especially those of her women and children.